Thank you for the introduction. Thank you, Professor Bishlawi, for inviting me. I'll briefly introduce what I do, and I'm an adult psychiatrist. I'm also the director of the psycho-oncology program at AUB. My specialty is actually in the psychiatry for the medically ill, so acutely and chronically ill patients, including the thalassemia patients. And I think I was invited first, I have no disclosures at all. And I think I was invited because we have a case that we had a month ago that I'll start with, me and Professor Tahir. And then I'll briefly discuss the evolution of the research on what I call psychothalassemia, which is very lacking for adults. The data that we have from Lebanon from Dr. Musallam and Dr. Tahir's group on depression, anxiety, and quality of life. Cognitive symptoms in adults, which I think are very underrated and undermined. And then future efforts and the challenges that are present in the current research. So the patient, هيك هخبركم من شهر, a month ago, Professor Tahir, Dr. Tahir calls me, and it just shows you how Ali Tahir takes care of his patients. He's not just a brilliant researcher. Calls me about a 20-year-old woman who is single, a thalassemia intermediate patient, who is known for years at the chronic care center in Beirut, who had no previous psychiatric diagnosis whatsoever. And so she called him asking him, Dr. Ali, and I'm in distress, and I cannot afford treatment for psychiatry, but I would like to even join a clinical trial if you have on psychiatry, so I can get help because I'm really suffering. That's how willing she was to get help. So she's single, she's an English literature major at the Lebanese University, and she's living with her parents and 2 siblings. And so, as I said, upon interviewing her, she was found to have 1 year of intrusive thoughts, images, and urges. And this is a patient that comes from a conservative religious background. Religion plays a big role in her life. And she was suffering from what we call purity, impurity, or tahara و najasa obsessions and compulsions. And these would take up to 5 hours of her day. So if you have 5, each prayer set would take بين الوضوء وتعيد الركعات وتعيد الصلاة, it would take her a whole hour. So that was severely impairing for her. And what she's described was that 1 year of living with that OCD was actually more distressing for her than going through the thalassemia for a lifetime. And so she was diagnosed with OCD. Upon follow-up just last week, she was doing almost 70% better, still had room for improvement. But I think that's what triggered Dr. Tahir to invite me here. And so I just want to say that despite the advances in medical management for thalassemia patients, and we are telling them, you know what, let's move you into adulthood, let's push you into adulthood, we want you to have a normal life. And despite thalassemias being, as a group, the most common inherited genetic disorders, the first study to document the unmet psychosocial need in adults was not until 2008, so only 15 years ago, almost. And so this was done by the Capellini group, and they did not, what they measured was quality of life. They did not measure depression or anxiety. And what they showed in their study is that actually, that was the interesting part that I thought would be nice to add here, is that the distress or the low quality of life caused by mental health was even worse than that caused by the physical symptoms. Okay, so the lower quality of life was actually was worsened by mental health, worse than physical symptoms. And then in 2 years later, so that's how psychothalassemia started for adults. And in 2010, a multinational group between Canada, the US, and the UK looked at the thalassemia longitudinal cohort. So they followed around 273 patients. Most of them were adults. 15% were still young adolescents. And that is what is considered by many the first measurement of depression and anxiety in an adult thalassemia population. So that was the first time, تخيلوا, 2010, يعني only a decade ago, that people started actually measuring depression and anxiety in adult thalassemia patients. And so what they found, and why I focus on this study so much, is in psychiatry, we don't have blood tests that can measure depression or anxiety. So most of the tools that we use are psychometric instruments, questionnaires that you give patients. And these are usually conducted or studied in the general population. So for example, if I give you a questionnaire and you fill out, they are based on 3 or 4 criteria for depression and you get a score, the general criteria for depression, you get diagnosed as depressed. And so the usual tools that are used in the general population, so for example, if I take that I have fatigue, that I have low appetite, that I have low energy, low concentration, low libido, all of these, I can get diagnosed easily as a depressed patient without endorsing that I have depressive symptoms. And so what the interesting part about the hospital anxiety and depression scale is that it removes these somatic symptoms, because that becomes problematic in patients that are medically ill, including thalassemia patients. So they only looked at actual depressive symptoms as a measurement. And so they had around 300 patients, only 11% reported impairing depression, but around 33% reported impairing anxiety. And the more important takeaway message here is that the older these patients were getting, the higher the risk of depression and anxiety. Obviously, as we know, the depression and anxiety were correlated with a higher risk with a higher problems with adherence, as you can see here. Both depression and anxiety were correlated with poorer, not just mental health quality of life, physical quality of life. And what I found was the most interesting part was, it was not statistically significant whether you had a more severe disease or more complications, you were still at the same risk of developing depression or anxiety. The only problem with the HADS is that it does not have a suicide risk assessment. Now in 2012, Dr. Tahir and Dr. Musallim and the group at AUB, I was not part of that group yet, conducted a study on depression and anxiety in their own patients. And I want to just give you, just think with me, in 2012, 10 years ago, it was a time when most of the studies that we had around that time were on pediatric populations in terms of mental health in thalassemia patients. 2, it was a time when people were starting to talk about quality of life, not even depression, anxiety, quality of life in thalassemia patients. And most, if any, quality of life studies in adult thalassemia patients were at the time done on TM patients. Very little was being talked about. It was just people were just beginning to talk about thalassemia intermedia and not being a mild disease anymore, and just to support. And so what they found is 53%, so almost half of their population, much higher than the number before, reported impaired emotional distress. These were between 35% reported depressive symptoms, 25% reported, I'll talk about the anxiety they reported. The I items, so each has a score of 3. And to be depressed, you have to score a score of 10. So immediately, if I say I'm feeling more tired, I've lost weight, I've lost appetite as a thalassemia patient, I can be classified as depressed, even though I have not endorsed any symptoms of depression yet in the medically ill. And the other thing is the group did not comment on, there's a suicide question in the BDI that the authors did not comment on. Despite that, the interesting findings that they had, and for anxiety they used a very nice tool because they separated between trait anxiety, so being generally anxious most of the time, versus state anxiety, so right here, right now, as a response to a negative event. And what they found was, بين thalassemia minor or thalassemia intermedia, there was no difference in the risk of developing depression or anxiety. If anything, the thalassemia intermedia were at higher risk of state anxiety for the same age and gender. So I think that was the beginning of people talking about thalassemia intermedia as having a poorer quality of life and mental health outcomes. So what makes a TM patient more vulnerable to depression and anxiety? Well, for one, obviously genetics. I won't bore you in the details of the psych genes here, but I want to tell you that 2 extremely important enzymes or genes for enzymes in metabolism of serotonin and dopamine are exactly the neighbors on the short arm of chromosome 11 of the beta-globin genes in beta thalassemia. So that could be one thing. Other factors are obviously factors involved in all chronic illnesses. People living with psychosocial health determinants. So frequent hospitalizations, being away from family, limitation of activity, relying on others, dealing with pain, fear of death is a big one. Low self-esteem and low body image, which I think with the improvement of treatment is no longer that big of an issue, I think, I hope. معك Dr. Tahir. But I think, but it was actually, it's interesting because if you see the study by Sabri and Salama was actually done on a pediatric population in Egypt here, and they were one of the first to show that body image and low self-esteem were really low in these children. So what makes TI patients more vulnerable to depression and anxiety? So as I said, TI no longer recognized as a mild form of disease. They have their own set of comorbidities. They might have a worse health-related quality of life by a study in the Lebanese group. And they have a later onset of diagnosis, so maybe they have not adapted to the idea yet of living with chronic illness. But also, this I found very interesting, is that, so in 2010, I think, yes, Dr. Tahir did a study. I think the point of the study was to show that thalassemia intermedia had a higher risk of thromboembolic events. I think 4 times higher risk than thalassemia major. But so they ran scans on the brains of people with TI that had no history of neurologic events, and they found that they had what we call UBO, unidentified bright objects, which are lacunar infarcts in the subcortical white matters. And these, if you look at the second images, and they found them in almost 60% of their patients. No neurologic symptoms yet. And so these scans from the second image are actually done on healthy patients that are non-thalassemic, that are first episode major depressive and major depression, and that have not yet taken any medications. And they still found lacunar infarcts in their brain. And so maybe the silent infarcts are not so silent. Maybe they could be the organic cause of a disruption in the neural circuits of mood regulation. But that is all assumption. So can depression be considered a patient-reported measure? I like the study by the same group. It's a small study by Dr. Tahir and Dr. Msalem. It's done on 32 patients. And I think it was prompted by the idea that, we want to show not just pharmaceutical companies. Pharmaceutical companies were pushing for patient-reported outcomes, and we want to show what an improvement in hemoglobin would do, and not wait 10 years for them to show that they decrease morbidity, but we want to show like acute patient-reported outcomes. And so they took these patients, adult thalassemia intermedia patients. 43% of them were depressed, and it showed a very strong negative correlation between hemoglobin and depression. So the lower the hemoglobin, the higher risk of depression. But they even identified a cutoff. So if you were below 9.5, you were almost most certainly going to get depressed, going to get diagnosed with depression. I think that's very interesting if you want to look at NTDTs and what the benefits of hemoglobin, improving hemoglobin could be. This is the oldest study by the Lebanese group, Dr. Tahir again. I like it because these are the quality of life studies. The quality of life, so the higher the score, the better the quality of life. And you can see the TM patients in the back, in the bar charts. And there's almost on all measures, the same transfusion-independent TI patient at the same age and the same gender of the transfusion-dependent thalassemia major patient will have a worse quality of life physically, mentally, but also socially on social domains and in bodily pains domains. So they really are not doing so well. And my favorite topics, this is the cognitive deficits in adults with thalassemia, and I think really this is something that needs a lot of attention and has not been discussed yet. This is a study done in Egypt, actually. There are studies done on kids, but none on adults. So this is a very nice study done in 2016 by El Habibi and colleagues. And what they did, they took 20 cases of thalassemia major, 20 cases of thalassemia TI, and 20 health controls. And they ran a battery of neuropsych testing, which is important, and I'll tell you why. Not just IQ, so they tested for IQ, they tested for visual spatial memory, but they also tested for executive functioning. This is how your speed of processing, how much can you stay attentive in a room, how much can you focus in a meeting, how your problem solving skills, your speed of processing. And these are things, so we're telling thalassemia patients, you know what, we want you to be adults, we want you to go to university, we want you to be functional in your jobs. and we're not recognizing that there are cognitive symptoms that are pertinent to the disease itself, and I'll tell you why the disease itself, not just education, that need to be addressed. And so cognitive, and so their findings were, they found that one, the healthy group, يعني controls, and the thalassemia as a group, there was a significant, which we already know, difference in the level of education or the years of education that they had received, one. Two, they found, what's nice about this study, they excluded depression and anxiety. So anyone that was depressed or anxious, they excluded him to make sure that they were not confounding any of the cognitive symptoms, deficits. And they found, one, there was a statistically significant deficits when you compare thalassemia patients, all of them, intermediate and major, to controls. And this was, statistically, it was not fully explained by the difference in years of education. So there's something inherent to the disease process itself. And both TM and TI had almost the same deficit, despite what we perceive as quote unquote the severity of the illness, and despite differences in the onset of blood transfusion and chelation therapy. So I think this is very important because it makes you think about questions for research. What do you want to translate? How do you want to translate that into practice? What treatment modalities do we have? And more importantly, can we now speak of a thalassemia brain fog? Because if we want to learn from other medical illnesses, cancer patients and their chemo brain, MS patients not on low-dose Ritalin stimulants so they can function better. These are executive functions. And even now, long COVID, a lot of people are pushing for research on long COVID, the cognitive brain. Can we give them low-dose stimulants and improve their functioning at work? So is it really fair not to give that chance to thalassemia patients? Because these are far more common and far more scientifically based, I think, than a long COVID. The missing link, I think, I could not find any studies discussing the suicide risk in adult thalassemia patients, but I think we have to take lessons. We don't have to wait for the studies. We can learn lessons from our pediatric populations. The first one was from a study done in Iran, and it showed that kids interviewed, 27% had reported a suicide ideation in the past year. And we know, we can extrapolate from the study, and we already know, as discussed before, that there's a higher risk of mental health burden as you grow older. So you can only imagine that the adults are not doing so well with their suicide risk, adults with thalassemia. Two, we can also learn lessons from other medical illnesses, from adults living with chronic illnesses. So there's a movement in psychiatry for the medically ill in pushing a new diagnosis as demoralization. These are people that are not depressed. They go on about their daily life normally, they can enjoy small things temporarily, but they cannot be future-oriented. They cannot anticipate pleasure. Yani, oh, I'm going to go see my grandkids and have fun. They cannot do that. And they have lost a sense of meaning or purpose in their lives. And why this is important? Because in the chronically ill, there are reports that demoralization, regardless of being depressed or not, is a greater risk of SI as a suicidal ideation, but also now we know of suicide attempts, not just suicidal ideations, than depression or psychological distress. I'll skip this part. I added this part because I really like it. This is Irvin Yalom. He writes about chronic medical illnesses and living with them, and he has a really nice concept that is called staring at the sun. And if you can imagine how hard it is to stare and keep staring at the sun. And I think this this is very relevant to our patient population because we're asking them to do a very difficult thing, to embrace two very contradictory thought streams. We're telling them, تعرفوا شو, you have to embrace life and enjoy life and live it well, but also you have to, on a daily basis, live with the idea that you might die, that you have your functioning might deteriorate. And so this is a very difficult thing to do that we're asking patients to do. And so last, future ideas for research. We should reframe our questions in terms of positive psychology. And instead of wondering what makes these patients depressed, we can ask, هدول thalassemia patients يلي مروا through traumas and difficulties and complications, the ones that are not depressed, how come are they not depressed? What makes them so resilient? And if we can find these factors, these determinants of resilience, then maybe we can foster them in our other thalassemic patients early on. We have to screen for depression and anxiety, preferably using the HADS. We can screen for suicidal ideation, so we should not only focus on quality of life, depression, anxiety, suicide, most importantly, cognitive symptoms. And going back to our common patient with Dr. Tahir, we should address other mental health diagnoses because the patient was suffering from OCD, which no one would have thought of because she was a thalassemic patient. I think I'm done. Thank you. Sorry, and thank you for staying this long.